We looked at the mechanism of action of antiretroviral agents and what DHHS guideline recommends for treatment of HIV patients. We ensured adherence to ART is optimized and designed an individualized monitoring plan. Now, given a prescription for antiretroviral agents, provide patient counseling for adverse effects. Alright, let's take a look at the food requirements for these various antiretroviral regimens. For many of these regimens, there is no food requirement, meaning that the patients can take them with or without food. However, note that anytime you have elvitegravir, it needs to be taken with food, as well as anytime you have rilpivirine in the regimen. So, Odefsey and Complera have rilpivirine, so that requires food. Juluca also has rilpivirine, so because of the rilpivirine component, food is required. And also in general, protease inhibitors, darunavir and atazanavir, they require food. That's to improve absorption. Efavirenz is the opposite. So efavirenz should actually be taken on empty stomach. And again, even for efavirenz, food will increase absorption. But because there are such neuropsychiatric adverse effects with efavirenz, we actually want to minimize the absorption of efavirenz. So that's why it's recommended to take it on empty stomach. In fact, so much so that more recently, a new formulation of efavirenz came to the market with a lower dose, just to make it more tolerable for patients. Let's take a look at the safety profile of some of these combination regimens. So lamivudine is included in Epzicom, and it's generally well tolerated. As a nuke, it generally can cause, general headache, some GI issues, fatigue, insomnia, and some increases in liver chemistry, but nothing too serious, including rash. So in general, these are very mild and very well tolerated. Now, these are the newest nukes. Some of the oldest nukes that are no longer used, they used to have strong inhibition of DNA polymers in patients, which would lead to lactic acidosis. So because the mechanism of action is the same, you will see that lactic acidosis will listed in the package insert of any nukes, but the risk is very minimal. For abacavir, of course, there is a risk of fatal hypersensitivity syndrome, so it is important for patients to have a HLA-B 5701 allele. And this actually is 5 to 8% prevalent in Caucasian population. Symptoms of this hypersensitivity reaction includes fever, abdominal pain, and rash, and usually is within 2 weeks of starting abacavir. But because it can be fatal, if this occurs, it must be discontinued. Abacavir must be discontinued. Another issue with abacavir is that from observational study, some data have suggested that there is increased risk of MI. Now, there is mixed data on this, so it's not clear whether the risk is real or it's based on biased studies. But because we have so many other options available for patients who are at risk of cardiovascular disease, it's best to avoid abacavir because we have so many other options. Let's take a look at Truvada and Descovy. So tenofovir, in general, if this mnemonic helps, there is a NOF in tenofovir. So N for nephrotoxicity, O for osteotoxicity, and F for Fanconi syndrome, which is, basically wasting of electrolytes in the kidney. But Fanconi syndrome is very rare. Now, with osteotoxicity, it's important to note that this is actually talking about bone mineral density loss. It is not myelosuppression. Of course, TAF can reduce nephrotoxicity and osteotoxicity with tenofovir. And lastly, emtricitabine has this unique adverse effect of hyperpigmentation, in addition to GI adverse effects, as well as mild increase of liver chemistries. With Stribild and Genvoya, which include elvitegravir, they should be taken with food. Elvitegravir is generally well tolerated. One thing that may occur in up to 39% of patients is proteinuria. And the cobicistat component can actually cause a small increase in serum creatinine. which can actually artificially lower GFR. We'll talk more about that in a future lecture. Bictegravir does not need boosting, so it's a much smaller pill, so it's very easy to take. It's once a day single tablet regimen, and it's very well tolerated. Now, these are the formulations that include dolutegravir. So dolutegravir alone is TVK, and then with 2 nuc backbones is Triumeg, and then with a single nuc backbone is Dovato, and of course with the non-nuc, Juluca is dolutegravir plus and non-nuc rilpivirine. Now, in general, dolutegravir is well tolerated. One thing that may occur in some patients is insomnia, and also dolutegravir has been associated with weight gain. And in recent time, more data has emerged that this weight gain can be problematic, especially in patients who already have issues with pain management and are at risk of cardiovascular disease. One thing to note with Dovato, because it has a single agent against hepatitis B, there is a black box warning that if someone does have hepatitis B co-infection, there has been lamivudine resistant emerge. So that's important to screen patients for Hep B and make sure that the patients do not have Hep B co-infection when using this regimen. Isentress, which is raltegravir. This was one of the oldest integrase inhibitors. The issue is that you have to take it twice a day, so it makes it, challenging for adherence. And more recently, a higher dose, so HD is for higher dose, came to the market. So basically, you can do it once a day. But still, these are pretty much big pills, and the patients have to take 2 pills once a day. And one unique adverse effect of raltegravir is CPK elevation. So this is, if you remember from daptomycin, can also increase CPK. So that's something to keep an eye on with raltegravir as well. Next, we have Cabenuva, which is a combination of cabotegravir, which is an integrase strand transfer inhibitor, and rilpivirine. Now, this is the long-acting version of rilpivirine with a half-life of several weeks. Now, it's co-packaged. It's not co-formulated. It's co-packaged, meaning that there will be 2 vials in the package. So there is 1 vial for cabotegravir and 1 vial for rilpivirine, and the content of the package shows that they actually give you everything you need, including the syringes and the needles. These are intramuscular injections that are injected monthly, and most recently was also approved for injections every other month. And this is significant because of the monthly injections or every 2 months injection. It could potentially improve adherence, and also it can help with stigma. So if patients don't want to have a bottle of ART regimen laying around their home, and they can just get this injection. Now, it is injected into gluteal intramuscular, so it's not something that can be done at the community pharmacy. So they do need to go to their physicians or other appropriate settings to receive these intramuscular injections. Now, because of the very long half-life of these 2 agents, there is concern that if you just inject it into somebody and they're going to have adverse effect, or if they don't tolerate it, the drug will be in their body for a very, very long time. So there was an optional oral lead-in where you actually give the short-acting version of these drugs, which are PO, and then see if the patients can tolerate before they transition to the intramuscular injections. Initially, this oral lead-in was required, but more studies came out that they actually found that the injections are very tolerable, so it's really no concern. But that's something that can be discussed with the patient if they're not comfortable getting these long-acting agents in case they don't tolerate it. There's the option to give the oral version to see if they tolerate it, and the oral version is called Vocabria. Now, another thing about this regimen is that for patients who are treatment naive, they do need to have their viral load suppressed before they can get this drug, because there's only 2 agents in there. So essentially they need to be on another ART regimen and have undetectable viral load before they can switch to this, to make sure that resistance doesn't occur. And that's for now. In the future, as more studies come out, that may change in the future. But currently, patients need to be treated on another regimen and have undetectable viral load before switching to Cabenuva. Now, anytime you have protease inhibitors, so darunavir and atazanavir, they have to be taken with food. Darunavir specifically, it's a sulfa drug, so we have discussed sulfa allergy before. It's not necessarily a contraindication, but something to be cautious, especially if you have so many other options. And someone has sulfa allergy, you can use something else, because adherence is extremely important. So the last thing you want is someone is having a reaction because of this sulfa reaction and they stop taking it. Now with protease inhibitors, typically dyslipidemia can occur, so especially increased triglyceride and cholesterol. So that's something to keep an eye on, especially with HIV patients. HIV itself is a risk factor for cardiovascular disease. One more thing with atazanavir is that a unique adverse effect is unconjugated hyperbilirubinemia. So that's something to monitor when patients are on atazanavir. Which basically, some of the manifestations is, when they have hyperbilirubinemia, they can actually start to have a yellowish color. So, some clinicians call this bananavir, referring to the yellow color. But, given that we have so many other options, they're really not a good reason for people to be on atazanavir anymore. Relpeverin should also be taken with food. The non-nukes are only active against HIV-1. They don't have activity against HIV-2, which in general is not an issue because HIV-1 is the most, by far the most common virus in the US. And, it can cause rash, hepatotoxicity, hyperlipidemia. So this also includes increased in triglyceride as well as increased LDL. And if patients were to overdose or achieve supratherapeutic concentration, it has relpeverin can also cause QTc prolongation. Efavirenz, of course, should be taken on empty stomach because food increases its level to unsafe levels, and there are serious adverse effects, so including depression and suicidality, including people who attempted suicide. So it's a very serious adverse effect. So it's important that the patient take it on empty stomach, or if they already have psych issues at baseline. In general, it's best to avoid this regimen. But if there is no other option for the patient, the lower dose is an option. CNS side effects, occur in up to half of the patients, and basically they resolve after 2 to 4 weeks. So these are general CNS side effects such as confusion, abnormal dreams, somnolence, impaired concentration, and occasionally severe depression. Now, one thing that also helps with abnormal dreams is if we tell the patient to take this at bedtime. Because if you take it in the morning or throughout the day, by the time it's bedtime, the drug is in the system and it can cause vivid dreams. And these dreams are, very problematic. Patients remember them, and, it can be very problematic. So one strategy is to, if someone develops vivid dreams, to take it at bedtime, because by the time the drug kicks in and you have sufficient concentrations in the blood, it's almost morning, so the patient is waking up, so there is less likely to be those vivid abnormal dreams. And lastly, we have doravirine, which is also a non-nuke that was recently approved, and it, compared to other non-nuked, it has improved safety profile, including less neuropsychiatric side effects. as well as better lipid profile. In fact, it does not increase LDL and triglyceride, and it's also been shown to, if anything, it's going to reduce or lower LDL and triglyceride levels, and it may also, on the other hand, increase HDL levels. So, from a lipid profile, this drug seems pretty good, given that HIV patients are at risk of cardiovascular disease. The other advantage of this drug is higher barrier to resistance, including it has been shown to maintain its activity against viruses that are resistant to efavirenz or relpeverin, for example. Currently, it's considered alternative because of limited data, so it's only been on the market for a couple of years. So, in time, it's likely that, either it becomes, first line, or, it might find its niche for patients who have resistance developed to other non-nukes. This concludes this presentation.